Welcome back at part 4 of respiratory medicine at the rate of Madicine. So we are continuing with pulmonary embolism, the left heart part. We are just left with the investigations, but that's the most important part because we have to see so many images, CT, 2D echo, a Doppler of the leg veins. We also have to say pulmonary arteriography, the important chest x-ray findings, like the backbone of pulmonary embolism and all the complicated stuff is stored in the investigations part only. So we have to give a lot of importance and time to that as well. So it's good we are doing it in a separate lecture, and this is part 4 of respiratory medicine. So as you know that this diagram is showing the pathophysiology, that all is clear by now. We have done the pathogenesis, the etiology, the clinical feature, the risk factors. So tell me quickly the clinical features we did in the last lecture also. Now I want you to keep telling me. First tell me what will happen if there is a massive pulmonary embolism. It will cause, like, it's causing a complete occlusion. So what will be the clinical features according to you? Think and tell me. Yeah, number 1, the most common will be dyspnea, a sudden onset breathlessness. You know, in totality, if you talk about pulmonary embolism, I'll call it PE, okay? If you call about PE, so what happens is that 70% of the patients, they will be asymptomatic. They will be sitting happily at their home and doing their daily activities, like, you know, watching TV, eating food, walking around, no hindrance in their activity level, in the physical activity level, and they will be all quiet and asymptomatic in 70%. But what happens, what brings them to the emergency department is that the sudden onset breathlessness, we discussed in part 2 also that what are the various causes of a sudden onset breathlessness: pulmonary embolism, pulmonary edema, an exacerbation of asthma or chronic bronchitis. Okay, it can be a sudden a massive pneumothorax, a spontaneous pneumothorax. Okay, so CHF associated with secondary edema in the lungs. So we discussed all these causes of sudden onset breathlessness, and one of them was pulmonary embolism. So that is the most common symptom, especially if it is a massive PE. The most common symptom will be dyspnea, that is sudden onset acute dyspnea. So what is the cause of dyspnea? You know it by now. There is a proper ventilation, but there is no perfusion. There is a lot of hypoxia. The person has to start to hyperventilate. Okay, the person starts hyperventilating. There is dyspnea, and there is pain associated with this because of the number 1. It can be the pleuritic chest pain because the lung infarction, it is occurring many a times in the peripheral region of the lungs, because these are the regions which are more susceptible to decrease in the blood supply because they are in the periphery and they will be supplied by much smaller branches of the pulmonary artery. And I told you the small emboli, they are much more dangerous than a large emboli, because large emboli, it will occlude the main artery, but then also the lungs, they have a dual circulation. But what happens when these multiple small emboli, they will cause all the end arteries, the terminal branches, they will block all of them. There can be multiple small infarcts in the lung, and that can cause chest pain. Okay, the third symptom will be in massive. Now think of the this right ventricle, there is no perfusion proper, so there is hypoxia and there may be cyanosis in few conditions, not always. Cyanosis is a less common feature. Now apart from that, you tell me about the symptoms which will be coming because of the left ventricle. We discussed there was a lot of compromise in the left ventricular capacity because of the shifting of the interventricular septum towards the left side. So because of that, there will be systemic hypotension. To accommodate for that, the heart will beat at a very fast rate, so there will be tachycardia and even palpitations. Okay, and because of this, another thing will happen, even the blood flow to the brain will decrease, head and neck will decrease, and the person can have syncopal attacks. So these are the clinical features. Apart from this, anything that we are missing, you want to tell me? Think of it and tell me any other clinical feature. I also told you that if it is a hemorrhagic infarct, it can also be associated with hemoptysis. It may be associated with a hemoptysis. Okay, in most of the cases, heart rate increases, but sometimes it is seen a paradoxical bradycardia. That is uncommon, but I just told you for the sake of knowing that mostly it is tachycardia, palpitations, but a few cases show a paradoxical bradycardia. And again, I'm telling you time and again, infarction of the lung is not a common feature. It occurs in few cases. It is more dangerous, and there is probability of occurring small infarcts if there are multiple small emboli. It can occur with large ones also, but because the lung has a dual circulation, both bronchial as well as pulmonary, there are less chances of an infarction. And so usually the person doesn't present with a very bad acute pain, because pain is coming from infarction and because of pleural involvement. But that is usually occurring only in few patients. Okay. Now the patient will also have what type of respiratory failure will the person have, like type 1 respiratory, type 2, type 1 respiratory failure, because there is hypoxia, because of VQ mismatch there is a lot of hypoxia. And also when there is hypoxia, the person starts to hyperventilate and undergoes into dyspnea, and because of that there is a CO2 washout. So there is hypoxia as well as hypocapnia or hypercarbia, in decreased CO2 in the body and also decreased O2, so decreased both. Okay, that is type 1 respiratory failure. And if I told you that, if I tell you, I ask you rather, that what will be PaO2 minus PaO2, that is the partial pressure in the alveolar, the partial pressure of alveolar oxygen minus the partial pressure of arterial oxygen, will this difference will it increase or will it decrease? P capital AO2 minus PaO2, alveolar as compared to arterial, obviously it will increase, because in the alveolar there is a lot of oxygen. We even discussed that alveolar dead space will increase, there is a proper ventilation, nothing is problematic with that, but the perfusion is decreasing, so arterial oxygen will decrease, and because of that PaO2, that is alveolar minus arterial, shall increase. Okay, if I ask you what is the most common cause of acute right heart failure, the most common cause of acute right heart failure is a pulmonary embolism, usually a massive pulmonary embolism. As I told you, the right ventricle was in grave strain, it did not know where to go, all it did was just shifting of the interventricular septum towards the left side, because right atrium is also not ready to accommodate and there is nowhere to go. So the most common cause of an acute right heart failure is nothing but pulmonary embolism. So it can cause right heart failure also. So it is causing not only compromise in the left ventricle, but it may be a cause of acute right heart failure, the most common cause indeed. What will happen to the JVP? There will be a raised JVP because there is a lot of strain over the right ventricle. There will be some backflow, so a raised JVP will be there, increased P2 will be there, and obviously heart rate will increase, respiratory rate will increase. So this is all we discussed about the clinical features. So specifically, if they ask you specifically that what are the 3 most important features of a massive P, then you will say the most common is dyspnea, then there will be hypotension and syncope. These are the 3 most important for a massive one. Whereas if they ask you for a small pulmonary emboli or multiple small pulmonary PE, what are the features, what are the 3 most common or important features you can suspect in a patient? The first will be chest pain, because I told you small infarcts are there. Number 2, cough and hemoptysis. Cough and hemoptysis may be there. Cough and hemoptysis, why cough? Because there is multiple small infarcts, they will cause a lot of irritation of the bronchus, and that will cause a cough. And hemoptysis, because of these hemorrhagic infarcts, there will be increased pulmonary arterial hypertension, there will be rupture of these smaller branches of pulmonary artery, and that will cause hemorrhagic infarcts. This blood will also come out in the form of hemoptysis. So that was all about the clinical features. Now let us come to the investigations. In investigations first, let's have a look a little bit at the theory, and then we will keep looking at the images because there are so many images, and we'll discuss all of them properly. So the first investigation that we go for is ECG. Like, it is not the investigation of choice, but I'm just telling you as it is written in the notes, and then I will tell you which investigation to start with and how will you manage the case. That will be done in one go. Right now we are studying each investigation, what is the utility, what is the advantage, and what are the limitations of that particular investigation. Okay, so investigations, they are not in the order of investigation of choice, they're just like that. The list is there, we'll complete each and every investigation, its use, we'll see the images related, and then I will tell you in practical use which one is good, which one is preferred for screening, which is preferred for particular indications, and which is not preferred, like that. Okay, so the first is ECG. Tell me, come on, fast. I told you the first sign in ECG will be sinus tachycardia. Don't say any other thing. First and foremost, say sinus tachycardia. Number 2, there will be all the features of right ventricular strain, right heart or right ventricular strain in the form of right axis deviation, right bundle branch block, and P pulmonale that you can see here. Right axis deviation, right axis deviation, right bundle branch block, and P pulmonale. Now if you want to have, you can have a look at this, but I'm not telling you right now what are the axes. Just know that normal axis is minus 30 to plus 90, and all these deviation of axis you can see in this. You can pause the video and have a look at it. Another very important thing will be S1Q3T3 pattern, which is seen around 10 to 12% of the patients, but it is characteristic. If they ever ask you in any exam S1Q3T3 pattern, they give you an ECG strip in the image based question, and and they also hint you that there is a tall S wave and a tall Q wave, and there is a T inversion. So you have to deduce that, okay, yes, this is the S1Q3 T3 pattern. So what it is, there is a deep S in the lead 1, deep Q in 3, and inversion of T wave again in lead 3, and this is seen in 10 to 12% of the patients of PE. S1Q3 T3 pattern, very important. Now coming to Ddimer. Ddimer, it is a good test. It is a very sensitive test. Like if a Ddimer test is negative, the person cannot have a PE. That is the importance of Ddimer test. It's a very sensitive test. The sensitivity is more than 95%, but the specificity is very poor. Because for that I need to show you the image. 1 minute. So this, the image of virtuous stride, this image, risk factors, we have discussed that very well in theory. Now this is D-dimer. D-dimer is nothing but it is the fibrin degradation product. You are seeing this fibrin is getting broken down by plasmin. What it breaks into is FDP, fibrin degradation products, and these are called D-dimers. So this is D-dimer. So D-dimer test. So therefore in the body, whenever a clot is formed in a physiologically healthy state, every time a clot is formed in the body, it undergoes spontaneous lysis. After 1 to 3 days, the lysis of the clot starts, and that is normal and should always happen in the body. But now in this condition, what will happen? So therefore I'm telling you the D-dimer test is a very sensitive test. Whenever there is any clotting condition of the body, a clot is formed and it gets lysed, so the degradation products of the clot are from fibrin degradation products. These are nothing but D-dimers. So D-dimer test is very sensitive, but it's non-specific, because you will see a false positive test in all the conditions wherever there is even a little bit of hypercoagulable state of the body, like in pregnancy, post-op condition, because post-op a lot of fluid loss is there, so there is a little increased viscosity of the blood. Similarly, after MI, infections of the lung like pneumonia, infections of the body systemic like sepsis, malignancy, again a coagulable state, and heart failure. So in all these conditions also there will be a positive D-dimer test, a false positive test. Therefore it's not at all specific, but it's sensitive. That means if the question says D-dimer test is negative, just rule out. It has been ruled out. Pulmonary embolism has been ruled out. Like in no case can there be pulmonary embolism where the D-dimer test is negative. If D-dimer is negative, it cannot be PE. It has to be something else. Just take PE out of your mind and look for alternative diagnosis. Okay. But if it is true positive, then it will be true positive in other conditions also. Any coagulable states of the body, it is true positive, like thromboembolic phenomenon, whether it's DVT, deep vein thrombosis, or it's P, pulmonary embolism, or even DIC, disseminated intravascular coagulation. All these conditions, there will be a true positive D-dimer test. Okay, and the normal value of D-dimer is less than 500 microgram per liter. Less than 500 micrograms per liter. That is the normal value. Now, D-dimer test is, if it is decreased, that means the person is on anticoagulant therapy. The clot is not getting formed only. So when and why will it get lysed? So D-dimer test will be negative. That means the D-dimer level in the body will decrease. Okay. So again, D-dimer, highly sensitive. Number 2, it is not a diagnostic test, but a test of exclusion. That is what I said, that it's not a diagnostic test, but the utility is that if D-dimer ever comes out to be negative, it cannot be P, that's it. It can be used as a screening test for diagnosis. Like there are certain patients who are undergoing hip surgery and they have to be immobilized for at least 10 days, 15 days, and there is a risk of these patients. There are other comorbidities also. So as a screening test in these patients, and will they develop pulmonary embolism, or if they have developed, to diagnose it in the early stages, because initially 70% of the patient, they will remain completely asymptomatic. So therefore as a screening test you can use it for PE, but not as a diagnostic test. Okay. And it is more sensitive for pulmonary embolism as compared to DVT. Like 95% sensitivity, as we discussed, is for PE, and if for DVT, deep vein thrombosis, the same D-dimer test will have a little lower, that is 80% sensitivity. 80%. Here it's 95%. In DVT it is 80%. Now, if they ask you that which investigation is the best when there is a clinical suspension, when there is a clinical, not suspension, sorry, suspicion. So when there is a clinical suspicion, which test do we go for first? Like which test from which test we start our journey in diagnosing a case of PE. It is CT angiography. It's the best test. It's CT angiography. It's a very good test, quite confirmatory, and it helps you to know that what is the site to localize the emboli, whether it is in the main artery, the trunk of the pulmonary artery, or at the site of its division into right and left branches, or in the right ascending branch, or in the right descending branch, left ascending, left descending. Where is the emboli? How many number of these emboli are there? Whether it is what all regions it is causing a strain over, all that can be seen with the help of a CT angiography. So it's a very good test to start your diagnosis from. Now there is another test, that is VQ scan, that is ventilation perfusion scan. This ventilation perfusion scan, it is a test, but it is usually not used much. Ventilation perfusion scan, it can be used in certain cases if the patient is number one obese, number two having a renal failure, and number three if the person is having iodine allergy. Obese, having a kidney failure, and iodine allergy. In any of these three conditions is present, you can go for a VQ scan and not for CT angiography. Okay, so what are the indications for going for a VQ scan or a VP scan, ventilation perfusion scan, if in case of obese patients? Number two, kidney failure patients, and number three, iodine allergy patients. Okay, was this clear? So we discussed till now, we have discussed about ECG, about Ddimer, about CT angiography, and VP scan. Now tell me something about Doppler. Will you not get a Doppler for the leg veins? Yes, because the pulmonary embolism, in case of pulmonary embolism, the primary site, in case of pulmonary embolism, the primary site is your deep vein thrombosis. Okay, and so you can also go for a Doppler study of the leg veins. So we have discussed this also: ECG, CT angiography, D-dimer, Doppler. Now coming to X-ray. X-ray, you know, it's so important, not only because of historical importance. Many a times, maybe if you are sitting in not a multi-speciality hospital, you do not have the CT angiography and all these facilities. So you should be experienced and knowledgeable enough as a clinician to make a diagnosis with the help of an X-ray. A good digital X-ray is like sufficient enough to make a diagnosis of PE, and it can be asked in any image-based question in any of these central exams. You need to know there are 5 important signs in a chest X-ray. Out of that, first I will tell you the 3 signs. These 3 signs, they are easy to make out in the X-ray. Other 2 are very difficult to look for. So there are high chances that these 3 signs only may be asked to you in the image. Number 1 is Fleischner sign, number 2 Phallus sign, and number 3 will be Hampton hump. Okay, so Fleischner sign is an enlarged pulmonary artery, enlarged, distended, or you can say dilated main pulmonary artery. If that is getting dilated in the X-ray, it is called Fleischner sign. It is positive in 20% of the patients. Now coming to the second, and that's Phallus sign. Phallus sign is an enlarged right descending branch of pulmonary artery. The right descending branch, if that is only distended, it is called Phallus sign. Now coming to third, and that is Hampton's hump. Hampton's hump is a peripheral wedge of air space, and that is indicating a region of lung infarct. That is lung infarct. Okay, Hampton hump. Now there are 2 more signs which may be difficult to mark or to get in an X-ray for you to clearly catch hold of them, but still we need to know from a theory point of view. One is Westernmark sign, another is Chang sign. Westernmark sign, and second is Chang sign. Chang's. Okay, you can see on the screen. Yes, Westernmark sign. It is a regional oligemia. You know, in the lungs never appear black. They always appear grayish, and there are so many small, like in a reticular fashion, there are these bronchovascular markings that are the divisions and the divisions and the subdivisions of the bronchial artery, and even the airways. They keep on dividing. So that is seen in case of that is seen in the form of bronchovascular markings. So this is an irony. The name is Westernmark, but there won't be any mark. The name is Westernmark, but there won't be any mark. That means in a particular region, there will be a regional oligemia. Means in that particular region, the blood supply is compromised. Because why? There is some emboli which is blocking, and past that emboli, there is no blood going there, so even the bronchovascular markings won't be seen in that region distal to blockade, and so that region will be seen in the form of a cutoff or a regional oligemia, because there is the bronchovascular markings suddenly get attenuated, and it is called Westernmark sign. So it's very ironical that in Westernmark sign there are actually no signs, means no marks in case of that particular localized area. Last we are left, and the sensitivity, if they ever ask you, Westernmark sign sensitivity is 14%, and coming to the chance sign is dilated right descending pulmonary artery with a sudden cutoff. Means it is one component is of Phallus sign, that is dilated right descending pulmonary artery, and the second component is of Westernmark sign with a sudden cutoff all of a sudden, because this is dilated and then there is a thrombus in there, so therefore there is a sudden cutoff, that is attenuation of the bronchovascular markings. So what are the 5 signs? I hope everybody is comfortable with them. Number 1 was Fleshner sign, the main pulmonary artery is getting dilated. Number 2 was Phallus sign, only the right descending branch is getting dilated. Number 3 was Hampton's Ham, simple, it was an area of lung infarct, wedge-shaped area, usually in the periphery of the lung, very close to the pleura, and this is the reason that many cases also present with pleuritic chest pain in case of PE. Number 4 will be Westernmark signs, where there is no marks. That means a regional oligemia or a regional cutoff, decreased blood flow, sensitivity is 14%, and loss is Chang sign. There is again it has 2 components. That means it is having a dilated right descending pulmonary artery with a sudden cutoff. Now let's do 2 more tests. We'll complete the theory, and then we will take our time and very nicely, easily, without any rushing, we'll have a look at all the images. Just 2 tests we need to throw some light upon now. One is pulmonary arteriography. Pulmonary arteriography, in this you pass a catheter from the femoral vein all the way up to the pulmonary artery. When it is done in case of when you are planning for an intervention such as an invasive treatment, you want to give the patient an invasive intervention such as thrombolectomy. Look at this definitive indication. It is only done when you have to go for a thrombolectomy or a thrombolysis. That means, like nowadays there is a trend of all these laparoscopic surgery where on a monitor you are seeing where your probe is, where your scalpel is, and where you are cutting and where you are applying the cautery. So in this catheterization, the catheter, it does not allow the space for a small camera to be passed. It is only a small hole that we make. So camera cannot be passed. That means imaging at that time during catheterization, during this intervention, cannot be done. So just before that, we do a pulmonary arteriography for the patient to know that where is the clot located, how big is it, whether it's hard, what is the consistency, will it be easy to break it with the help of thrombolysis, or will it have to be completely excised out, it means thrombolectomy. So all that, to find out all that about the clot whenever we are going to plan in the near future an invasive intervention such as thrombolectomy or thrombolysis. Before that, just for visualizing and checking out where the clot is, how big it is, all that thing is served by pulmonary arteriography. So it is never ever done for any regular patient. It is only done, for example, if the patient is unstable patient having a low BP going into hypotension, for whom we have to go for a thrombolysis, means a catheter directed thrombolysis or a thrombolectomy. In this patient, we first quickly get a pulmonary arteriography done to specifically localize the clot and blah 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 blah, and after that we follow it up with our invasive intervention. No other indication, no other patient will be asked to go for this pulmonary arteriography, will be subjected to this test. Okay, so it is the most specific test for establishing a definitive diagnosis. Obviously it is definitive diagnosis. You are looking at each and every pulmonary artery, its branches and branches and branches. A pulmonary arteriography, obviously there can be nothing more definitive and specific than this test, but we don't do it for regular patients. Okay, and it can detect an emboli as small as 1 to 2 millimeters. Of course, it's very specific. We have to see if there is a small emboli also, but the patient is becoming unstable. We have to remove that emboli through a catheter mediated thrombolysis. So we need to know where is the emboli, how big is it, how many numbers of emboli are present, and specific site of the emboli, because we have to introduce a catheter, and all these regions, they are very sensitive regions. If we put it at the wrong place and maybe there is a rupture of the main pulmonary artery, there will be a lot of bleeding and it will be difficult to save the life of the patient. So we have to do with great precision this procedure. For that we need to know well in advance, and so we go for pulmonary arteriography. It's a very good specific test to make a definitive diagnosis of pulmonary embolism. It can detect even emboli, very small emboli, all that stuff. So it's a gold standard for diagnosing PTE, pulmonary thromboembolism. Gold standard test, very specific test, all that done, but not never ever done for a regular patient. And other limitations are that it's expensive, it's invasive, and it's time consuming. So I told you the definitive indications, only which particular patients will be going for it. Unstable patients for whom you are planning thrombolectomy or a catheter directed thrombolysis, only these have to be subjected to arteriography. The last is 2D echo. 2D echo is a very good test. In 2D echo, I told you in the earlier lecture, we see the McCullum's sign. Come on, who remembers the McCullum sign? McCullum sign, that is right ventricular wall hypokinesia. Where is the right ventricular apex? The apex is having a normal mobility, but the right ventricular wall is having a hypokinesia. That is echo. Other things are that in echo you can find the enlarged main pulmonary artery. You can see the right atrium and right ventricle. If they are also getting enlarged, there is a strain over them. And you can also measure, another very striking thing about an echo is that you can even measure the blood pressure in the pulmonary artery, and you can rule out pulmonary arterial hypertension, right? So that was about the diagnostic test. Now we are only left with this thing called the Wells criteria, Wells scoring system, and the treatment. Let's first look at the images. I want you to try and tell me first, and then I'll let you know what is showing what. Yeah, let's start. First, I'll do this image. They can show you this image. So, in the treatment, we'll come to the point that in case of pulmonary embolism, sometimes for a long-term management of case and for prevention, we ask the patient to get an IVC filter inserted. So, go for an IVC filter. So, they can show you this image in any of these exams, PG entrance exams, okay, USMLE. They can show this image and they will ask you that which of these structures numbered 1 to 8 will you introduce the IVC filter. They will give you a big case that will take 1 or 2 minutes reading, blah 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 happened, so happened, and finally they will ask you that the patient wants to go for an IVC filter insertion. So which of them marked 1 to 8 is the structure in which you are going to insert that filter? Tell me, guess, make guess, do some guesswork. Done. So what did you say? How many of you said either region 4 or 5? Anyone thinks it's 4 or 5? You're absolutely wrong. If anyone thinks 1 or 6, you should literally worry, man, take some rest, because how can you say 1 or 6? Is it looking like inferior vena cava? That's out of the question. Did anyone say in 8? What is 8 showing? It's showing air fluid level. 8 is your stomach. Yes, now I'll tell you. Okay, so whatever was your guesswork, let's see how accurate and smart you are. What is 1? 1, see what is happening. This is the right side of the liver. Okay, this is the right side of the image. Yes, this is right side and this is left side, and this is anterior and this is posterior. Anterior, posterior. Now quickly tell me, what is 1? What is 1? This 1 is your liver on the right hand side. This 6 on the left hand side will be your spleen. Okay, now 8th we have discussed, it was your stomach. What do you think is 5 and 4? 5 and 4, yes, 5 and 4. This 5 over here and 4 over here, these are respectively the right and left kidneys, retroperitoneal, close to your vertebra. This is your vertebra. Okay, now tell me. Wait. Okay, what is 7? This little 7 QT 7. The 7 is your adrenal gland on the right side. Yes. Now tell me, what is 2 and what is 3? 2 is present little bit in the central, a little bit towards the left, and right is present little bit towards the, and 3 is present little bit towards the right. So obviously 3 will be your IVC and 2 will be your aorta. 2 will be your abdominal aorta. So that was the basic, that this is how you have to interpret a CT. There will be 3-4 organs which will be seen. And another thing which is not highlighted in this image, this organ over here, it's the pancreas just behind the stomach. Okay, so like that we'll do other images also. Now a little orientation is there in your mind. Now this was actually in the abdomen. Now the other images for CT angiography, they will be related to your lungs and chest region. So this is showing that at what level the image has been, at what cross-sectional level we are. Now tell me what is what. Come on. Yeah. What is this? This is all that vertebral body. Now tell me what is this? What is this? So this is your ascending aorta. So this is your ascending aorta. And this behind is the descending aorta. Okay. And if I ask you this small region over here, it is your SVC, superior vena cava. And now if I ask you this, what is this thing? It is your pulmonary artery. And if you can look over here, this thing like this is present, and this is your saddle shaped emboli that I was talking about, a characteristic saddle shaped emboli, a massive emboli which is present at the level of division of the pulmonary artery into this thing over here is the right branch of the pulmonary artery, and this over here is the left branch of the pulmonary artery. So the saddle shaped emboli is present at the site of the bifurcation of the division of the pulmonary artery into its right and left branches. This large saddle shaped emboli, it will cause a lot of destruction, massive PE, pulmonary embolism. Okay, so I hope everything in the image was clear. Yes or no? So abdominal aorta. Now this is again a plain image. This time you have to tell me. Okay, what is this? Okay, what is this? Yeah, abdominal aorta? No, ascending aorta. Okay, what is this? Descending aorta. Yeah, and this over here is your SVC. Okay, what is this thing coming over here? This is pulmonary artery dividing into the respectively right and left branches. And this over here, what you are seeing, this is your saddle shaped emboli. Okay, good enough, easy. Yep. CT angiography. Now all the images are like that. This image, what is it showing? It is pointing towards a saddle shaped emboli individually. This is ascending aorta, descending aorta. This is showing your SVC, superior vena cava. And in this, the 3 is that structure, that is IVC, in which you should introduce that filter. This is deep vein thrombosis, the swollen reddish appearance of the affected limb. Here you can see this woman is having chest pain. Okay, so sudden onset breathlessness may or may not be associated with chest pain. Okay, chest pain is characteristically seen more in the small emboli. This is hemoptysis again because of a hemorrhagic infarct. Okay, seen in case of small emboli. This is the characteristic S1Q3T3 pattern. In lead number 1 you can see a deep S wave. In lead number 1 you can see a deep S wave. In lead number 3 you can see two things, again a deep Q wave and inversion of the T wave, and inversion of the T wave, S1Q3T3 pattern in ECG. But the most characteristic pattern is, firstly you have to say sinus tachycardia. Wow. Now coming to the lungs, you have to tell me, it is encircled. What is it showing? Come on. This is Hampton's hump. Excellent. If you told me, good enough. That means you are very much into the lecture, you are attentive, and plus you are applying your knowledge. So this is characteristically a wedge-shaped infarct. I told you, usually in the peripheral region, and this is Hampton's hump. This is one of those 3 features that they will always expect you to know. Easy ones. Okay, now Fleshner's sign. It's written Fleshner's sign, distended central, means the main or the central pulmonary artery is distended. How do we make this out? I'm going to tell you. This is there. Usually we don't get such a profound shadow. Usually it would have been limited only till this much area, but now it is distended, so you can see this extra because of distension. It is appearing much more bigger and more conspicuous. Okay, so this is there. So again I'm telling you, if it was normal, this structure was normal, so it would have been just like this, little bit of the shadow seen, this much shadow seen. But now since it is a distended main pulmonary artery, a bigger shadow will be seen, Okay, good enough. So that was Fleshner sign. Yeah, what is this? Can you tell me? This is little, see, Phallus sign will be same. In this the main artery was there. In Phallus sign the same image will be there. In Phallus sign the same image will be there. Like in this image you can see that the distension is present in this region. In Phallus sign the right descending artery will be lower, so the same thing will be here, means more dilatation will be seen in the lower part. This region will be still normal, little thinner, and more dilatation coming in the lower part. That means only the right descending branch will be primarily involved. Phallus sign. This is one sign which it's little like difficult to appreciate, but still you can see in this region, in this, how do I use, wait, I'll encircle. See, in this region you can see the bronchovascular markings. Here also you can see the bronchovascular markings. Here in this region so nicely you can see the bronchovascular markings. All these regions you can see the bronchovascular. Even in this region you can see all the bronchovascular markings, and in this region also they are quite conspicuous. But only if I show this particular area, it is devoid of most of the bronchovascular markings. It's a dark area. Okay, this area, it's a dark area devoid of the bronchovascular markings. So this area is showing regional oligemia. And which sign is it then? It is the Westernmark sign. Okay, regional oligemia or sudden cutoff. What is this? This is a VP or a VQ scan, a ventilation perfusion scan. We can see for each lung which lung is involved, more right lung, left lung, which particular lobe of the lung, which particular region of the lung is involved. And this is second last image. What do you think it is? Come on. This is pulmonary arteriography. So in this also we can see specifically that here you can see the arrow is pointing in this area, there is this obstruction. So specifically this emboli, this obstruction is being characterized in this. This is pulmonary arteriography. It is a best test, gold standard test. If you want to plan for a patient with an invasive procedure like this catheter, you will pass. And if you want with the help of a catheter to thrombolize, to break this emboli or to excise the emboli out, if it is a big emboli, a hard emboli, you won't be able to lyse it, then in these particular patients we first ask them to get a pulmonary arteriograph done. That is this image. The last image is showing a 2D echo. It is showing a 2D echo. It will show in 2D echo. There we can see the involvement of the arteries, which artery, main pulmonary artery or its branches, even right atrial, right ventricle, if they are also enlarged, if they are also involved. And even we can even measure the blood pressure. So we can even rule out pulmonary arterial hypertension. The artery pressures in the pulmonary artery will also be shown to us. Okay, so this was the images in this, and coming back to the theory, and one image was here. And see, this is, I told you, in the veins you always get a red thrombus, means which is mainly comprising of RBCs and fibrin, and there are very few platelets, whereas in an artery you get mainly a platelet thrombi. So this is in veins, red RBC, fibrin thrombi or a red thrombi in the veins, and this is causing all the DVT, PE and all the other places. It will get dislodged and then settle somewhere else. And this is your Doppler for the leg veins. So this is showing the vein which is having a thrombus. Artery also is shown. So this Doppler study can be done for the leg veins. We discussed this. We'll discuss as a last slide certain preventive measures. First, let's do the well scoring, the treatment, prognosis, and finally the preventive measures. Okay, so we